はい。
Okay.
おお、セクションジャパン。素
Okay,
晴らしい。
I presenting today the complete case of complex cyst resolution from the initial case for the follow-up from 6 months. So, patient with 40 years old come to our clinic with these findings on right side of the maxilla. And the first assessment was to know what kind of lesion is this. So the question is, the first point is to the compensation or remove the total lesion. This is the point. Remove this teeth or not. So this is the crossfire of this situation. So the first point is understand how is the correct characteristic of this lesion. So it look this by tomographic reconstruction 3D. And look that. So we have discontinuity in vestibular point and discontinuity on palatine 4. So the idea was where the most important approach we can do for palatine or for vestibular, to use a reconstruction first with removal of the teeth and do a reconstruction with, for example, titanium mesh, or just only put biomaterials inside the lesion. This was a very questionable point of different points of view. My question on the first time was, if I do the approach on the palatine, you have a different kind of mucosa of vestibular. However, we have a very, very important microvascular comes from the posterior and the median part. So this is one, for me, was the most important part, is not only put the biomaterial inside the lesion to gain on height, on width too. So this is another point of view. And if you look carefully, we can view the expansion of the cyst on the sinus floor and the nasal floor too. And for the surgery, we must do very, very carefully, because the idea for the access is not to contaminate the sinus floor with this kind of lesion, independent of the type of the lesion. So on the first time, I made a biopsy. So this is in another point of view of the lesion. Palatine and vestibular. So for the first biopsy, the suggestion of is periapical inflammatory cyst. So the suggestion is total excision of the lesion. Okay, perfect. So the approach was vestibular for the resection of all the lesion. So if you report before for the tomographic view, we see we have a very, very good bone here. So we must understand when you put biomaterial inside different kind of cavities, we must understand that the idea of microvascular is the most important. So we must gain microvascularization from this part, from the upper side, and for the palatine side too. So we remove all the lesion, and carefully we treated these borders and do this incision like a periodontal approach for incisions today, not using the papilla, because here is the very statical problem. Besides removing, we do apsectomy on the lateral incisor and remove all the apical previous treatment of the other teeth with root canal treated. So the difficulty here is on the palatine side, you have the teeth and the other part of the lesion that comes and involves the palatine side. So when you touch with instruments the palatine side, you look and see the movement of a palatine mucosa. So, as I suggested, remove all mucosa, the lesion. And for the first, this is the IPRF. So IPRF is a liquid and for injection when aggregate with biomaterial. The osseous substitute. So when you use this, use the white tube. So you use 2,000 of RPM for 4 minutes. So when you use the centrifuge with less time and less velocity, you have different kind of aggregate. When you put this biomaterial, we use the Orthogen, is a Brazilian product, similar with Geistlich products, and Tachygraft is similar to the Geistlich membrane. So part of this membrane is used and works at a barrier, is different from the point of the mucosa. On contact of the mucosa works as a barrier, and in contact with the biomaterial is function as a membrane. So part of this biomaterial is organic and part is inorganic. So when you put this biomaterial with IPRF, you can get this one. Is the sticky bone. So it's easy to work with the sticky bone. You can put on the lesion and you work with a very facility. And the cellular is all here. So you can put on the membrane too. And now with 270 RPM, 2,070 100 RPM with 10 minutes in centrifuge with ready to, when you have inside the aggregation, you have this LPRF. So after removed all the lesion, we put first the membranes over the lesion on upside, on the lateral wall in palatine region, and the idea is preserve all this region, osseous region, to avoid have two portions of let's say as wound healing. So if you remove this tooth first, you have wait for wound healing. So you have many problems, aesthetical problems, prosthetical problems. So we decided to conservatory and maintain this tooth. So you can put this all this material up and posterior on the lateral wall. And now we put the membrane. So in contact with the mucosa, we put the LPRF membrane. And with the contact with bone substitutes and osseous, you use this membrane, because resorption are different in different times from membrane and LPRF. All of them is a real biomaterials, but with different characteristics. So we use the sticky bone and we reallocate the sticky bone inside this lesion. So the advantage of use of sticky bone is is a malleability of the sticky bone. If you use the classical technique, you can put in the small parts, so you have more time, and the possibility of have a gaps is in major scale. After the put all completed all the lesion inside, we put the membrane, tachygraft, and put over them LPRF in contact with the mucosa. And now we have the suture. So this is a simple panoramic X-ray after 6 months. So, well, good. We have all complete this region. Made all, look this. This is an important point. We made apsectomy here. So the idea too is to stop this lesion still working. But panoramic is not enough. So I asked for the patient to do tomography. So this is the first. Remember, this is the first. And now it's the control. So we have a port of macrovascularization from here, and from here. So the preservation of the alveolar ridge, for me, besides the removal of the lesion is the more important than to remove this teeth and wait for the possibility of the dual implants here. So it's the most important to understand the real necessity of the patient and more conservative surgery. So this is the final treatment. It's interesting because we have no contact during the surgery with the inside the sinus. So we avoided very carefully remove the lesion and not contact with the sinus mucosa to avoid contamination. So the result is no sinusitis after all these 60 months of control. And we have stopped the lesion and look this inside the palatine, and this one. So the idea is the portion of this substitute bone is organic, is restored, and new bone formed, and the scaffold, the responsibility of the inorganic part of the substitute. So understand how the substitute works is the most important of the label. Domo arigato.
Thank you very much, Dr. Vannucci. Does anyone have any questions to the Dr. Vannucci? I have one question. PRF is useful for soft tissue healing or hard tissue healing?
Yes, yes. When you use for hard tissue, you can mix with IPRF. So you will have a sticky bone. So how it works is different from soft tissue. When you use soft tissue, you use the membrane that you provide by the red tubes. So to gain this LPRF socket, for example, socket blocks, you can use the LPRF with red tube with more time of centrifugation. So you have, when you have more time of centrifugation, you have more aggregate. If you use the red tube, that inside you have a coagulation, for example, coagulation form for the tube. The white tube have no coagulation, so you have liquid. To have the solid clot, you must use. So the soft clot you can mix, for example, with biomaterials, but it is more difficult. When you use white tube to gain stick bone, you must wait for 20 minutes, more or less 20 minutes, to do the sticky bone. However, in the time of surgery, if you were speaking of time during surgery, I use the red tube first. You can use time work of 2.5 hours of time work. However, when you use IPRF, you have a short time of use, less than 1 hour, because any use liquid you put on this biomaterial to aggregate the biomaterial with the collagen of the organic part of the biomaterial. This is important point. So if you take there the IPRF, he will coagulate. You can gain, it's like a jelly, and not works with when you mix. So it's important is you put when the phase is liquid, not is the phase of gel, this jelly. So you must understand this part of this time surgery. However, timing of the surgery is very, very important. To we don't have pitfalls during surgery. This is interesting.
ポ先生使ってますか？ PRF とか。
あ、僕使ってないです。
ないですかね。あ、
うん。
そうなんですかね。なんかあります質問とかは。
いや、使ってないんで。大学とかで使ってるんでしょうかね。リー先生とか。 どうなんでしょうか。
Dr. Lee, do,
I
do you use PRF in your university? No?
not in Nagasaki University, but last time when I worked in Malaysia, I used wands, and I only used the sticky bone. I didn't do the PRF membrane, and I didn't use the IPRF as well. Only to make sticky bone.
Dr. Jennifer, do you use PRF in your Peru?
Yeah, I use here like membrane, like sticky one. Also, I'm using like you can do it like soft blocks or mixing with ozono. This is like you can activate PRF with ozono. So it's really. Also,
The
Dr. Marcelo come to my country to teach PRF, so it was really great
the,
last year.
the interesting point of use this membrane, this elasticity. So most time when you use some kind of membranes is very difficult. But with this PRF membrane, you can work very good. It's very and you get very good results. As I said last week, I hope this is a miracle, this surgery, but I think the planification was very good then. Of course, the techniques is important, but the planification of the surgery and the approach, vestibular approach, was the better choice than Palatine choice and not and choice to choose to not remove the tooth was better for the patient and better for us too. It was very.
Also, I have like a comment, like I have also a case of cyst, and it was a case from university, and there is a maxillofacial oral surgery. So when I was talking with him, we decided to approach also palatal, as Dr. Marcelo said, and we have completely different approach because he decided to wait and don't feel the cyst. So I was willing to take like 6 months. Maybe we have like bone reduction. So because he is like he's more like don't want to take risk of infection or any or maybe things because of teeth infections and but in my opinion I wanted to do it like Dr. Marcelo do it, like decontaminate all the place and bone field deletion. But since was a patient from the university, the doctor has to be decided how the patient had to be approached. And it was really interesting, and I want to see what happened so that maybe we have a contract from different
Yes.
approach. Like Dr. Marcelo have the vestibular approach, and we have like palatal approach. And what happened? And we don't do it anything, just pure inside.
Yes, because sometimes if you have not root canal treatment, you must do in the same time the best choice. Do decontamination from the teeth and remove of the cyst. And if you put not anything inside, you have a remodelation of the bone. So you can have depression as a result of your surgery. Of course, for me, the like a rod, for example, we use extension rod for this situation. You can imagine, for example, if you remove all the tooths to planning for implants in the future. So you have a major flap. So you have a major points, different points from revascularization. So this was my thinking and thinking, what's the best point to avoid pitfall on the results. So I was very carefully on the removal of the cyst to avoid invade the inside of sinus, because we not know how is the potential of the contamination of these lesions. So we must understand it. The problem is not the different point of views, because each patient has different kind of resolutions. We must understand how is the better for the situation properly. No? But this understand PRF and bone remodelation and wound healing for me is a passion.
大丈夫ですか？ Are you okay? ドクター・ジェニファー。それじゃあ、最後、記念写真撮りますか？ Please take a screenshot. ね。はい。ね、いいですかね？はい。はい、チーズ2。はい。はい。ありがとうございました。では、それではまた、来週は高橋光先生がやりますんで。あ、星先生ですね。ASS さんとか募集してますか？
いや、今んとこまだ、なんとか。
大丈夫ですか？小樽でなんかね、札幌で勤務したい子いるので、もし
なんか、
希望があれば、
わかりました。
小樽 SC 学校に、あれしてください。何件かありますよね、近畿はね。
うん。
すいません。なんかもしあればお願いします。
はい。うん。
上浦先生、
はい
ピーズブリッジ
うん、
を
はい。
作れないんですけど、
うん。
うちの技工士作れないって言ってて、先生のところに出す。
出してね、印象送ってくれる？
トリオスのデータ
スキャンのデー
とかで。
タ、作るから。
承知しました。また技工だとか、
そうね
教えていただければ。
はい。お願いします。
すみません、
はい
失礼し
お願いし
ます。
ます。それでは、See you next week. Thank you, Dr. Banucci.
Thank you, Dr. Banucci.
Thank you very much for the
Thank you.
opportunity
Excellent
to
case.
share.
Thank
Thank
you.
you, Iguchi.
Have a nice weekend, guys.
Thank
Nice
you.
weekend.
Have a nice week too.
Yeah.
Later. See you.
Thank you.
Thank you so much. See you next week. Thank
Yes.
you.